and the STT College for giving me this opportunity. My first visit, I'm enjoying it, and Dr. Krabanda has already done a beautiful introduction to the subject and in quite some details here and there also. But when I talk, you will find a few repetitions here and there because the subject is cleft. Okay? So I was wondering, today is a day when we are all having different kinds of omelets, but the subject, the basic ingredient of the egg is there. So the basic ingredient in today's talk is all cleft, and you would find a little different flavor when I talk, what Dr. Kravanda talked, or what Dr. Sidhu is going to talk. And this is my current status. I work for 4 afternoons or 4 half days as my orthodontic practice, and 1 or 2 mornings I spend at the Center for Special Children as an honorary consultant, and give free checkup and free oral health guidance. And other days I'm free and have a better opportunity of enjoying life than having done 8 to 5, 8 to 6 job for 6 days a week at PGI for 40 years. All right, just to share with, I want all the students to please note this because it's a very favorite slide of mine to the students, because the word orthodontia, orthodontics and dentofacial orthopedics need to be very clear to you. Now orthodontia, that is ear is a condition, especially a medical condition, for example amnesia, etc. So it was earlier known as orthodontia, but later on the word X was added since 1930s, and that is how it became from orthodontia to orthodontics. But if you meet old timers, even Dr. Sidhu is not around at the moment, they would always call it a isko orthodontia ki zarurat hai, I work in orthodontia, you know. But things have changed and you got to make the difference. And even today you have to be very clear. And you all know that today your departments are known as orthodontics and dentofacial orthopedics. And I want the students to please note that ever since 1986, T.M. Graber, who has done excellent work, probably exemplary work in orthodontic publishing and book writing. So he was the one who was the editor-in-chief of the AJODO, and he changed the name from pure orthodontics to orthodontics and dentofacial orthopedics, because we do a lot of dentofacial orthopedics as orthodontists. Okay. Now the main objective of this presentation is to sensitize and empower the students, the future orthodontists and other dental specialists, maybe I'm told your periodontists and oral surgery people around. So there will be something for everyone to taste and grab it from what I taught, and go as 0.4% to 4.7 per 1,000 live births. Dr. Sidhu rightly emphasized in the morning. When we talk all these anomalies, many of these children are stillborn, so we do not know how many of them. So for all practical purposes, the incidence is always talked in terms of live births. And live births also till the survival of about a year or so, because some of them may be lost even within 1 year of life if the problems are more severe. Okay, now let's look, the highest has been reported among Afghans, that is 4.7, Japanese 3.7, Caucasians 1.7, Indians 1.4 on an average. Different regions may have a different incidence. And among blacks is the least, that is 0.4. Now according to WHO, the incidence of cleft is given by Dr. Krabanda just to positive family history of cleft, missing or chronical maxillary laterals, maxillary hypoplasia, consanguinity, marriage within the close relatives is one of the major risk factors in certain communities, but not all over. Chronologic events which may cause all this, families, at least some of them, and when there's syndromic. So here's a family which we were treating in PGI, and there are three generations. The grandchild, that's father, and father's father. They all three had cleft, and they were all being treated at PGI. That's how they came there and we recorded. Now, as Dharmendra said, you have basically two varieties, syndromic and non-syndromic. In syndromic, there are more than 400. Sorry, from 300 I have come to 400 even. Because there have been so many, hundreds of them. Okay? So, include cleft lip and palate deformity. But most of the common ones which are there are the Vanderwood syndrome. I think I'll show you a case. Behr-Robin, Stickler, Velocardiofacial syndrome, Treacher-Collin, orofacial digital syndrome, golden heart, so there's a number of, I can't name all these 400 ones here. But please remember that 50% of cleft palate alone and 30% of cleft lip and palate are syndromic. So, cleft palate alone is more syndromic part of rather than cleft lip and palate. So, this figure is very important to remember and it's very clear. Now, this is the Vanderwood syndrome. We have followed this boy. He had a sister also, same, father the same, and his sister's next generation, the third generation also the same. So this is a very typical familial cleft, and Vanderwood syndrome is characterized by lower lip pits, labial pits in the lower lip. This is typical of Vanderwood, and besides the cleft. Okay, so this is the additional feature in these Vanderwood syndrome cases. Now, coming down to classification, we also follow with very simple, descriptive I call it. You have unilateral cleft lip and palate, that is UCLP, could be right or left. Bilateral cleft lip and palate, BCLP. Cleft palate alone, CP or CPO. Unilateral cleft lip only, UCL, it could be right or left. And bilateral cleft lip only, BCL. And subclinical, subcutaneous and submucous clefts, which are the microforms, which apparently are not there, but then there is a cleft underneath the skin or underneath the mucosa. But the numerical classification, I'm fond of it because Professor C. Balakrishnan, who is considered to be the father of plastic surgery, was working at PGI, and I started my cleft work under him or with him, and he gave a very simple classification in as early as 1968. And group 1, cleft of the lip only. Group 1A for alveolus, cleft lip and alveolus. Group 2, cleft palate only. And group 3, cleft lip, alveolus and palate. Okay? They are pure, they could be appearing pure or in combinations of above groups, and also right, left in combination or isolated right or left. Now here's a subcutaneous cleft. Dr. Krabanda was mentioning about it. From a distance, you don't see much, no problem. Okay, but here you see there's a little notch, and there's a little deformity here, which might look like a scar, but it is not scar. But more important, if you look at the nose, it's showing the deformity, error deformity of the nose on the cleft side, also subcutaneous cleft, right? Now, UCLP left side, you have alar and premaxillary deformity. Bilateral cleft, lip only. No. And this is a unilateral cleft palate, alveolus and microform lip. Again, the lip is not apparently cleft, but there is a subcutaneous. But he has a deformity of the alveolus. And with the alveolar deformity, you have deformities of the teeth, rotated, extra teeth, right? So this is a unilateral cleft lip, palate and alveolus in the microform. There's bilateral cleft, cleft of lip, alveolus and palate, and cleft of lip and alveolus alone. Then bilateral cleft lip and alveolus. Now when we are talking about bilaterals are, I would say, very, very complicated. They have so many problems, because they have unusual growth of the septo-premaxillary complex. Because of the cleft of the lip, the premaxilla is not attached to the lateral segments of the maxilla, As a result, this is free to grow, and usually many of these cases will present with a very prominent premaxilla in bilateral cases. Then isolated cleft of the palate, and also more common among females. Then this is a combination of cleft lip and isolated palate. Okay, this cleft of the lip is there. This is not continuous, so it is not a UCLP, but it's the cleft of the lip and isolated palate. Now, this is the midline complete cleft, very rare, as Dr. Karanta was asking. In my 40 years of experience, I have just seen one patient who also did not survive, but I had the fortune of taking a picture of this child, and this is the rarest of the rare, but one should know that this also can happen. But then we are talking about midline clefts. Now this is something I want to thank Dr. Edinwala, a famous plastic surgeon, dedicated his life to cleft surgery in Tichur. And I borrowed this slide from him because this is something I would say they are incomplete midline clefts of the lip of different varieties, but I have not seen it. So it could be something to do with the region or with the population, I'm not sure. But I'm sharing with you because I found this something which is very rare. I haven't seen it in my area of cleft patients here. Dr. Karanta was talking about Simonot's band. So this is a typical Simonot's band here. Okay. And as he said, you have better control. Even the premaxilla is not jutting out so much because there is a pull of the Simonot's band and it is keeping the premaxilla into position. So many of the cleft repair or the cleft research, you have to mention about Simonot's band was there or not, because it has an influence on the presentation of the premaxilla and the facial structures. Now let's look at the common dental anomalies associated with cleft lip and palate. Maxillary deficiency is very common. Alveolar deficiency, maxillary collapse. Then you have missing or conical maxillary laterals, supernumerary and fissural teeth, missing premolars, rotated and hypoplastic maxillary incisors, and compromised maxillary midline, delayed eruption of teeth. Now, above may occur in varying combinations and proportions. And there are also cleft-associated common ENT problems: otitis media, effusion, OME, acute otitis media, tympanic membrane perforations, varying degrees of hearing loss, and compromised speech and language development. Now, various degrees of hypernasality is a common denominator of all palatal clefts. Even after surgery, as earlier mentioned, these children have a near normal speech, but never a normal speech. If a cleft child with a reasonably good speech is talking to me on the phone, I can still make out that this is a cleft child and not a normal speech. Okay, so that is because they always have a little nasal twang when they speak, even after the best of care. So let's remember that. So when the child is born with cleft lip and palate deformity, psychological trauma, counseling, reassurance, pre and post surgical photographs are shown. We will show you some. Then feeding difficulties. We have special instructions: spoon, palady, special bottles, special nipples. But let me also tell you that feeding plates are rarely used. There's enough research to prove that feeding plates do not really help, rather they create more problems. But in a rare situation where the child is really unable to feed without a plate, it could be given as a last resort. But for every cleft lip and palate or every cleft child, because I keep finding case reports coming in our journals, giving one or two feeding plates, and you think we have done a big job in cleft lip and palate care, which probably is not very good or very true. Now, if you show the parents a child, and Dr. Karanta said you make them meet the another cleft child's family, excellent if that's possible. It should be, because if you're running a cleft clinic, there would be parents, so you can tell them to intermingle and share their experience. And initially you can just show them that this is the cleft deformity, and then after surgery your child is going to look from here to here. It's very reassuring for the parents of such a child. And the feeding babies, you have those nipples with those extra holes or cross-cut nipples where the milk has to flow under gravity and the child has not to suck it. That's the basic rule here. And then, or if you can, if you feel, you can even give them, you can give them all right. The spoon feeding is pretty good, and this is the palliative, which is nothing but this is from the South social milieu where the children are fed with a palliative like this, and this is nothing but a bigger spoon with a spout, so you can feed the child with this. And this is even we have adopted in our institute and very useful for feeding the children with clefts. Palliative. Okay. Now, it's very important to give these special instructions, which is usually given by either the surgeon or the nurse who's been trained to take care of these children and their family. So, semi-prone position, the child has to be slightly kept upright. Spoon feeding, palliative feeding, soft bottles with cross-cut nipples. The most important thing is frequent burping. Now, all mothers know, or grandmothers tell, that if you feed the child, you have to burp the child to remove the extra air which may have been ingested while feeding. Now, these cleft children ingest a lot of air while they are being fed. So, you have to do extra effort to remove that air. So, you have to do extra effort to do the burp in these children to remove the extra air. But still, we would say encourage breastfeeding if possible. If not, then let the mothers express the milk in the container and use the breast milk, because there's nothing better than the breast milk. Now, cleft care team, we talked. Surgeons could be plastic, pediatric, oral and maxillofacial. I would say anybody, because we don't want to get into the fight who should do and who should not do. I would say anybody who's able to do a good job, has been trained, is competent, should be doing the job. Okay? So that's why I have named all the three here. Okay? Then orthodontist, again I would say experience in cleft care. That's more important. And ordinary orthodontist has no idea, who has not been exposed to cleft care in cleft orthodontics. That's why the need, and I'm glad to hear from Dr. Kharbanda that they started a special fellowship for 2 years on cleft orthodontics. Even at PGI, we openly have a 3-month program, but you have to pay for it. It's the other way. And you can come and get your exposure on cleft care for 3 months as a visiting clinical assistant. Okay? But more important is that you have to have experience in cleft care. So I'm sure most of you today would go back by the evening and confident that you can also handle these children pretty well. Speech therapy, again, you have to have people with experience in cleft care. Any ordinary speech therapist may not be good. And then you have pediatricians, ENT surgeons, sociologists, child psychologists, geneticists, pediatric dentists, all the people who are sitting here from pediatric dentistry, please remember you have a very important role to play. And then prosthodontists and others. I would say the key word here is interdisciplinary, preferred over multidisciplinary. Little word about it. Interdisciplinary means you have to interact with each other. You have to sit together and see these patients, speak the common language, understand everybody's language, and then treat these children. Okay? There are terminologies you may not know as an orthodontist, but once you start working in a team, you know the plastic surgery's terminology, and they know your terminology. Okay? So that is what is interdisciplinary, very important. And the child doesn't have to go from one room, from one building to the other building, which usually will happen in most of the hospitals. So if you say that my cleft child is seen by 5 specialists, but if they have to go from one building, one room to another room, that you may call it as only a multidisciplinary, but not interdisciplinary. So I hope that you people are here doing interdisciplinary care and not a multidisciplinary care. That's very important. But all said and done, team care is the best care. Now let's come down to timing of primary cleft surgery, which was already covered. Rule of 10. Lip repair is the first thing, around 3 months, 10 weeks of age, 10 gram hemoglobin and 10 pounds of weight. If the child is healthy, everything is good at this age. Palate repair could vary. Some people are doing it at 10 months, but I would say on an average 12 to 18 months is an ideal age for doing it. But you have to be clear that there is no anesthetic risk and the tissues are manageable. Some people are saying, oh, I'm doing newborn baby surgery. Okay, you can do newborn baby surgery, very good for the parents because you hand over the child to the mother with a repaired lip, beautiful. But most of the surgeons do agree that it is the tissues are so friable in a newborn child, it's very difficult to handle them and treat them. So in all probability, in all fairness to the child, I think the best age of 3 months is a golden rule which is being followed almost all over the world. Okay, and then you have to also see that some people are talking about the fetal and neonatal lip repair. Neonatal repair is okay if possible, but still it's not a very good idea with many surgeons. But there are research going on that if you could, as we said, if an ultrasound you can find the child is having a cleft of the lip and palate, and by about 7-8 months, when the lip is, reasonably formed, and if a fetal surgery could be done, so we are waiting. I think it has been almost 30-40 years that some people are trying, but that day has yet to come. But the way science is progressing, I think the day would be there, one that these children will undergo fetal lip surgery at least, if not palate. Okay. We have pre-surgical infant orthopedics. Commonly used procedures are the pre-surgical nasoalveolar molding, popularly known as PNAM, then Latham appliance, McNeil's appliance. But I find that most of these appliances are a very big burden onto the child and the doctor both. And a simple strapping of the lip in bilateral cases is a good thing to do. And most of these are limited to few centers because these are need lot of expertise and plus lot of burden. And also questionable long-term benefits of these. We are still not sure whether doing all these things in a newborn would have long-term benefit or not. Now, passive strapping, as I said, is the premaxilla in BCLP is beneficial. And feeding appliances, once again I say, the feeding plates are rarely used. But we have to see that the burden and benefit equation is balanced. Now, just to give you an idea, what is PNAM? Okay, this PNAM apparatus and PNAM has been done. Okay. Now, I say period between 3 to 10 years of age is the golden period for speech and dental care, including early growth modulation of the maxilla. Continued and coordinated speech and dental care, because most of these children would need active speech therapy. So we try to make it a point that whenever they are coming for speech therapy, their dental appointments are also scheduled for pediatric dental care. Now, the pediatric dental care would include cleaning of gum pads with clean and wet cloth wrapped on finger. That's what most of the pediatricians will tell you. Then you subject them to assisted toothbrushing because child may not be able to brush himself or herself very well, so the parents got to do it. Fluoride toothpaste after 3 years of age. Diet counseling is very important. So we have to tell them about sugar clock. We have to tell them about restriction of sugar to the right time. And quantity is immaterial. I think most of the pediatric dentists know that. So if you can time their intake of sugar or sweet things to the main meal time, there is no problem. Okay. Then regular follow-up every 3 to 6 months, depending upon how often the patients can come. Let's get down to speech therapy. In general, it is aimed at improving venopharyngeal valve after palate repair. Blowing exercises, that is a simple physiotherapy of palate with whistle, balloon, bladder, candle, wind blowing, musical instruments could work as a speech therapy, simple speech therapy or exercises for the palate. But let me tell you that after having worked with so many speech therapists who are doing a lot of research, now I have modified. This is the addition I have done to update myself, and that they do not favor these exercises, probably because they think that their importance is getting, diluted. But let me again tell you that anecdotally, I have seen number of patients who have been subjected to singing. All the cleft patients whose parents have subjected the children to some form of singing, they have an excellent speech. So I think this needs to be researched and maybe need to be modified, or the speech people have to tell me more. But I'm just sharing my anecdotal experience on this subject. But then comes the definitive speech. When the speech therapist knows that these are the problems, so they'll give a definitive speech therapy which could start at 3 years, and home training instructions. Then they have to call to the institution for training of speech specific defects. And as I said, we got to combine them with dental appointments so that the burden of care or the burden of travel for the child reduces. But keep it in mind, all this is a long and continuous process. Palatal or residual and prealveolar fistulae, Dr. Kramanda mentioned for these. You have residual anterior and hard palate area. Dehiscence could occur anywhere. If there is a dehiscence of the surgical repair of the palate, it could occur anywhere. And you have then untouched. Sometimes the procedure is such that the prealveolar fistula is left to be treated later, but it has not been touched therefore. But I think the key factor, as Karbanda also mentioned, it is symptomatic or asymptomatic. If you see a fistula in the palate and is not causing nasal regurgitation of fluids, it is called asymptomatic. If there is a fistula, this fistula could be invisible. There's a small, gap because of the failure of the suture. Visibly the soft tissue look fine, but if the patient tells you that when I drink liquids or milk, it comes in my nose, then it becomes a symptomatic fistula. So that needs to be treated. But a visible small fistula which is asymptomatic probably can be left as such. But remember that these fistulas are more due to the technique than due to surgical failure. Okay? So do not give comments, yeah, teri surgery theek nahi hui hai, tera to fistula bana hua hai. This kind of, we should avoid making such comments, because it casts some aspirations onto the surgeon's ability, which is not fair, and we have to be very fair to our colleagues on that count. All right. So this is the residual palatal fistula, anteriorly located. It does not contribute to bad speech. It is asymptomatic, so you can just forget and leave it without getting anything done about it. Now let's come down to early orthodontic and orthopedic interventions. Face mask, reverse twin blocks, derotation of incisors, correction of incisor crossbites, and then guided eruption and holding arches, and arch preparation for alveolar bone graft. So these are the early orthodontic or orthopedic inventions. So just showing you a case with all those pictures of a face mask, a girl with cleft lip, repaired cleft lip and palate, and she had face mask for a couple of years, and then followed with active orthodontic therapy. All right. And towards the end, if you can, now you can see what the face mask has done. If you leave this child without a face mask, okay, yes, I agree with Harbanda that you can give them a chitka, absolutely good, because the mandible has a tendency to overgrow. But if I leave this face unattended, where will it go? I will be showing it in my second lecture, what really happens to these children. But then, having undergone speech therapy, the face mask therapy, and active orthodontic treatment, I hope you can appreciate the face. There is no deformity or mid-face deformity here, because the face has grown very well, the nose, the upper lip, everything is good. Okay? So this is the combination of face mask followed by orthodontic therapy, and no surgery has been done as far as the orthognathic surgery is concerned. Okay? Now, rotated incisors could have this problem, all right? They would maybe injuring the lip inside, and this soft tissue trauma, if we can address, and I try to address this with very simple simple orthodontic attachments here, and I can derotate and make the, okay? So from here to here, I think it's, and this is another case where you have a 90-degree rotation and it is causing diastema in the lower incisors. If I leave it for 6 years for comprehensive orthodontic treatment, but then the child will grow with this kind of face and psychosocial problem. This is his face with rotated, and this is, so I think a lot of confidence comes, and we are still within the normal bone, and if he has to undergo a bone graft, because bone graft is something which I would say that is not really possible and practically done in most of these cases. But wherever possible, yes, bone graft should be done, and provided you are going to use that alveolus for putting an implant. If you do a bone graft and don't use the alveolus for an implant, the bone graft does not stay, it dissolves away over time. All right. So early incisor correction and crossbite correction. I'm very fond of these expandable screws in the sagittal mode, which work very well. So you can correct the crossbite. This is another case where we use the sagittal. Okay, you just put it on the border band. It's almost like a fixed appliance. Then you can activate and you can correct the premaxillary. If you leave this child, this is around 8 years of age. If you leave this child to be treated for his premaxillary crossbite at 12, 13 years, his face is deformed quite a bit. And I was talking to your oral surgeon that anterior maxillary distraction, I think this is also kind of a maxillary distraction in bilateral cases, but where the surgery is not really essential. Okay, so you can procline or you can reposition the premaxilla because it is quite pliable, it is quite loose, so this gives way and there. And if you can let the child achieve this, his mid-face growth definitely is going to improve a lot. Then arch preparation for bone graft, which is a must. So you can see before the expansion or the arch preparation, so the gap has increased, now it's ready for a bone graft. So if you have to do a bone graft, the arch must be prepared. That is very, very important. Now when we're talking about bone graft, it could be primary alveolar bone graft at the time of lip repair, which many surgeons do. The other one would be before the eruption of canines, secondary alveolar bone graft, and the late alveolar bone graft even after the eruption. If you are wanting to move the teeth into the alveolus, then you can do a bone graft and you can move your teeth into the grafted bone. I would give my conclusion that alveolar bone graft is an optional procedure with variable success rate. And It is better done by the oral and maxillofacial surgeons today than by the plastic surgeons. That's my conclusion on this whole contradictory topic. Okay. Alveolar bone graft and dental implants, as I said, if you want to do alveolar bone graft, and it must be used because you have to put in implants. Now here is a cleft patient who had alveolar bone graft, and these are the areas where the implants had been put. You can see the implant, and then finally the prosthesis happened. So it's a cleft case, and that's a beautiful arch. Okay. So thanks to the successful bone graft, which if possible should be done, and only if you are wanting to use implants. If you are not, supposing the socioeconomic status is different, and patient says, no, I just, then you can, prepare them for a bridge or for a RPD even, I would say. Because we have patients of different socioeconomic status. Look at some secondary surgical procedures. Okay. There are two basic primary. Now this is a typical case of columellar lengthening. This is the columella which has been lengthened. Okay. Slightly improves the nose tip, but not fully. Huge fistula. She had 2-3 surgeries and the failure. And how do you close? And the oral and maxillofacial surgeons and plastic surgeons or cleft care surgeons do a beautiful work. That is tongue flap, and I think this is one of the excellent tongue flaps I have ever seen. It was done by Dr. Mustafa from Mangalore. For one of my patients who used to go all the way from Chandigarh to Mangalore for her. Or in cleft care, I would say it's more demanding than routine orthodontics. It requires special interest and skills, requires innovative approach, and unfortunately there is lack of dedicated and trained manpower, which I hope is going to increase and improve as AIMS has taken a lead, and we were already doing this kind of post-MDS training or fellowship, and for 1 to 3 months as a clinical attaché. But you have to have alignment has been achieved, quad helix has been used for expanding the maxillary arch, okay, and finally, and you look at the retainer, this is a soldered retainer because we have increased the intercanine width, so we have soldered it at the back, but here it is strong and is going to maintain the intercanine width. And option in select cases, we have maxillary advancement, mandibular setback, then bimaxillary surgery, anterior subapical mandibular osteotomy, and maxillary distraction. Okay, so the non-oral surgery people should also concentrate, because this is not purely for surgeons. Left palate case, she was being treated at some place, but for her maxillary retrusion and collapse. And when you get a collapse like this, please do not try to expand the maxilla to match the maxilla. Realize that if you hold these models, okay, and I bring it forward, this is larger, now looking expanded. So I had to contract this rather, okay. Okay, the same thing you can, and this also gives you an idea how much advancement you want to do. And you can measure it in millimeters, because your ultimate success of the surgery depends on what occlusion you get. Many of the surgeons, with due respect, they say, no, I have done plating, nothing will happen. Even the plating would not hold the maxilla and the mandible in the correct. They are bad. They are good for educating the patient, showing the patient that this is what we will do and we will look like. But also with a caution, because what you show on the limited, 15 millimeters, 20 millimeters, any amount, okay? Now, this is another mandibular anterior subapical osteotomy. Here, if you can appreciate, the premaxilla is in crossbite. There is some crowding in the lower interior. Profile you can see, she has a chin which is also practically missing. Now, this is pre-surgery, now it is being pushed. And the advantage when you have an orthodontic appliance, the surgeon is very happy. They don't have to of this kind of a, and finally you get this kind of a result. Okay. Now we're talking about maxillary distraction, external distractors, down, you know. This must have been about 15-16 millimeters of maxillary advancement or maxillary distraction when we started. Okay, now, as I said, there was a time when we did not know anything about distraction, and there was a time when we did not have a good oral surgeon also with us. But overdenture. All time, this is a huge overdenture. You can see some change in his, we did not do much orthodontic, but if you can concentrate the amount of lip repositioning we could do with this overdenture, this is about 12-13 millimeters. So his profile improved a little bit, but he was not too happy. In many years he was wearing this for him. Okay, now at this stage now he has undergone oral and maxillofacial surgeon, and which would not cost more than $200. But it worked. We must have used this in almost 15 to 20 cases. But now today we don't use this, we use the red device because we have the luxury of having it being gifted to us by somebody. Now this patient comes at this when she's an adult, so we decided to do, okay. We have some time to talk about Gosselin yardstick because it's something most of the ortho. It stands for from the word Great Ormond Street, London, and Oslo, Gosselin, and it included assessment of severity of malocclusion and difficulty in correcting it. Okay, this was introduced and by Mars et al. You can note down this and go through this article. This is in Cleft Palate Journal 24. Please note this down, and you must go through this article. And whosoever is the next examiner coming, I will tell him or her to ask you about Gosselin yardstick. And if I'm not going to be the examiner anyway. Okay, but I can always tell my youngsters to do that. Okay, so it was a series of study models of 30 cases in early permanent dentition. They were selected from the files of hospital of sick children at Great Ormond Street, London. Great Ormond Street is the famous street where all the medical practitioners of international fame work. All the film stars and others go there for their all kinds of plastic surgery. So there is a sick children's hospital which is very famous. So Michael Mars was working. Depending upon whether their prognosis was excellent, that means they only needed minor orthodontic treatment or no treatment. Please remember this. This is very Gosselin 1. Okay? And Gosselin 2, which is there, upper incisor getting recruited. And Gosselin 3, profile is changing, but still orthodontic treatment is explained to the politicians and the bureaucrats. A very, very simple system of traffic light system. Okay, red is, I would still say that patient whose soft and hard palate were closed before their nasal stents or conformers, vestibule spacers, obturators, retainer from global partial denture, which I call them as stage 1, and speech wells, which are again very rarely used. Surgery, this is a conformer, which has been made in clear acrylic after taking an injection, and very simple. And vestibular spacer after surface repair, and that is a 3-in-1. Now this patient has undergone, he doesn't want a tongue flap, he doesn't want an implant, so I just, and he has undergone orthodontic treatment, okay, from there to there. So we give him a 3-in-1, which I call retainer come obturator from RPD, which is good enough for him because it doesn't allow any relapse of the treatment and closes. I would say they are needed and useful only at specific times, but must be discarded as and when possible. Okay, and I call obturators are like crutches and should be discarded as early as possible. Okay, if you undergo good therapy, undergo good physiotherapy, your crutches may be taken away. But if you have lost a leg, then obviously you need a crutch. That's the difference. Till the time you get a prosthesis for you. So they are like crutches. Now, a small word about obturator complications. This patient was given an obturator. So to conclude, we are just coming down to it that let's remember that if we compare operated and unoperated cleft cases, operated cases have collapsed maxillary arch, straight or near normal growth, palate has not been touched, the lip has not been touched, and profile is good. There could be a small involvement, some involvement of the tooth facial growth. And again, I would say there are conflicts between centers, and science is a derogatory language, and the literature has gone back, has innovated or started using the word adhesion. Okay, so if you give any instructions to your patients, and if he or she adheres, he is showing good adhesion. It may be a little bit pertussive, but not as pertussive as DCL. In 1981, he was 14 years old boy. We were not doing any of surgeries at that time, maxillary surgeries or advancement, other things. We did little bit of orthodontics, whatever was possible. And today, since this boy still lives in Chandigarh, he comes and meets me once in a while. Now he's 45 years. What I'm trying to show is that facial changes after 31 years, you can appreciate what happens to this. Look at his face, look at his upper lip, you know. So this could happen over the years. So sharing these changes in 31 years in a cleft different palate male. Now finally, Dr. Nanda has shown a different graph. It's almost the same thing. Every comprehensive. Okay. Then maxillary growth modulation, again, this period, after the patient, again said to getting dental care must continue, then they are ready.